to travel all the way. Okay. Yeah, that's good. And then both of these work. Do you want to, the podium mic picks up pretty well. See, 1, 2, 1, 2. How's that coming through? Pretty well?
Yes.
Okay.
Yep, I can hear you.
It's better. Now when I move my head, my chin won't hit the microphone. It's coming through Zoom power too.
Well, I think we will get started. So there's not much delay further. Thank you for your patience as we work through the technology issues. And thank you for all of you coming in person and the folks who are online. I really appreciate it. As you guys, some of you know, this is the annual memorial lecture for my dad, which was established 5 years ago with the help of Binter Center at the UVM Medical Center and Department of Neurological Sciences. I just briefly will talk about my dad like I usually do, and then we'll introduce our visiting speaker. So, I mean, essentially, my dad had a good life of 63 years from 1956 to 2021. The date here you see is that of his passing away, 4th April 21st, 2021, at the height of pandemic in New Delhi, India, when he had. But going back to his origins, he was born just about 10 or 15 miles off New Delhi in a small village called Kekara, where I was also born, and I was there until 5th grade before we moved to Delhi. And, you know, he was son of his dad and mom, and had 3 siblings. My mom, he married as an arranged marriage. He had 3 children, including me, my brother, and my sister. And then, you know, their husbands and wives. And he was the grandfather of 6 grandchildren. And in terms of his education, despite coming from a family of essentially no education, no resources, he educated himself pretty well and did 2 bachelor degrees and an economics degree. And he was a pretty religious and family man, born and raised too. He served as a high school teacher for 30 plus years. He taught English and economics in high school in one of the Delhi government school until his retirement in 2015. And he had Parkinson's disease for 13 years. You already hopefully read briefly about his Parkinson's disease story and journey in our pamphlets. I'm not going to repeat it. And I always conclude by saying he was a life worth lived, over 64 years. And finally, I would say, like I've said it 4 years ago, this lecture was primarily set up by me as a way for me to feel that he's visiting me, because one of the things which always will remain with me, that he could never visit me. And the year he passed away, he was scheduled to visit me for the first time in the United States in May, flights and everything. And obviously, he unfortunately passed away. So I felt like this way I have a chance to bring him here. That's the main reason for me. Over to transitioning to our visiting speaker. Usually Dr. Boyd our division chief of movement disorder, does this introduction, but unfortunately, he's not able to come today because of some personal reasons. So I will take that liberty to do that briefly. Dr. Lawrence Golbe is our visiting speaker. He's visiting us from Rutgers University, where he is an emeritus professor of neurology. He's also, although he's clinically retired for last few years, but he is still very active academically. He's on several senior level positions in CurePSP, which is a patient advocacy foundation. And he really has spent his whole career on PSP as a very focus, both clinically and research-wise. And again, I hope you had a chance to read over in the annual memorial lecture brochure. The last thing I will mention before transitioning to Dr. Golbe is that it's interesting. The lecture title is PSP, and my dad had Parkinson's. But one story I can share right there with you, which is connecting the dots. My dad, he was first diagnosed with Parkinson when I was in final year of medical school, and it was already like a surprise and a lot of setback for me. And then a few months later, a movement disorder specialist in my school, in my hospital, saw him and put down on his papers for paper PSP. And I didn't even know what was PSP. And then I went home and read about it. And certainly Einstein's theory of relativity became true. PD was better than PSP. So there is that connection. It didn't turn out to have PSP, but that's sort of the story. But clearly, PSP and other Parkinsonian disorders are related family. So I did request him to give a talk in this topic, which is very dear to him, but try his parts with Parkinson's, how these disorders inform each other. And I think we are in it for a treat today. He told me that he has spent disproportionately more amount of time in this presentation. This is the first time giving presentation. So with that, I will transition over to Dr. Golbe.
Go ahead.
Dr. Gupta, we're seeing the notes view.
Sorry for the technical difficulties again. So we can do the extended.
That's perfect. Thank you.
Well, I think yours.
No. I don't want the audience distracted by my next slide.
Yeah.
Pause for laughter.
I guess the microphone's working.
That looks good.
Yes. Okay.
Well,
It's not showing.
okay, maybe this will do for you, where you can see this on your screen and present viewers are still seeing.
That'll do.
Okay, thank you.
Thank you. Yeah, this is good. All right, well. In your father's memory. And thank you to Dr. Calabrese for making sure that there's resources available for visiting professors to come give lectures in person, because not every medical school is able to do that, especially since the financial stresses starting with COVID and now with research funding. So kudos to you guys. So let's get started here. Here are my disclosures. Don't know what that's from. My big consulting work for pharma companies has been for trial design and teaching, examining physicians how to use the PSP rating scale. I have no financial interest in the success or failure of any of these companies, and
Dr. Golbe, the PowerPoint is still not moving. If you give me 1 second to troubleshoot it, I apologize for this delay sincerely. Hopefully this will do now. Thank you so much for your patience.
Okay, good. Yeah, this is what I was after from the beginning. Good. And none of the treatments I'll be mentioning at the end of the lecture are FDA approved for the indications I'll be talking about. Here are the 4 diseases that I will be focusing on. These are the major. I'm getting a notification here that something is down. This will be fine. All right, so you can see slides, and I can see in the other screen, I can see the slides. Sorry about that. Stay close, Deepak. Yeah. So these major ones, you see they are called atypical Parkinsonian disorders. Don't like the word atypical. It tells the patient that they're weird, that there's something odd and dangerous and malignant about their condition. We want everyone to realize that these are diseases in their own right. They deserve to be researched in their own right, and treatments specifically for these diseases. And that's what we are trying to do. There are lots of other diseases that can cause motor Parkinsonism. And this is a list of diseases that are either rare to begin with or common, but only cause motor Parkinsonism of patients. And as you see, they all of the major medical these structural things, infectious, genetic, toxic, immunological, and metabolic. And those RXs mean that they're treatable. Most of these are treatable in some way, even if it's just to provide genetic counseling or to separate a patient from a toxin or to give immunomodulation or to fix a metabolic derangement. I highlighted Wilson's disease here because, are there any medical students in the audience? Yes. Okay. Never miss a diagnosis of Wilson's disease. You can make the difference between giving the patient a normal life and condemning them to very bad motor and cognitive issues and early death. All right, so here's the plan. Starting with pathology. As kind of a side issue, I want to point out that normal pressure hydrocephalus is probably not just a mechanical issue with blockage of uptake of spinal fluid into the arachnoid villi up at the vertex. There's probably a neurodegenerative component, and I've listed there reasons for that. So if a patient fails to respond to a shunt, this is probably why. Now, there's a long list of pieces to the puzzle. We don't know where the pieces fit in together, which ones are upstream and downstream of each other, which ones are interacting with each other. But we've got problems with protein misfolding. This is the name of the game. Pretty much every slide I'm going to show you today is going to talk about protein misfolding. The neurodegenerative diseases have that at their core. A lot of these proteins that aggregate, first they misfold, then a lot of them don't have any native folding. They're just kind of loosey-goosey in the cell, and then they misfold for unclear reasons. There are strains of the proteins, which I'll talk about in a subsequent slide, what that means. They propagate themselves in a prion-like fashion because the first diseases that were found to do that were the prion diseases, where the protein that was misfolding and aggregating and propagating through the brain was the prion protein. It spreads cell to cell, and it templates its misfolding pattern. So if the first copy of the prion protein or the tau protein or the alpha-synuclein or what have you, if it misfolds for whatever reason, it's able to copy that misfolding onto its normal neighbors. And then they're each able to do the same on their normal neighbors until these toxic misfolded proteins kill the cell and they spread to other cells even before the original cell dies. Another element is synaptic dysfunction because the synaptic vesicles don't get shepherded to the right places. The microtubules get destabilized in the case of tauopathies because one of the important normal functions of tau is to stabilize microtubules. Axonal transport and maintenance is affected because microtubules are important there. There's myelin loss from oligodendrocyte dysfunction because the oligos are often the first class of cells that are affected here. So there's demyelination. There's dysregulation of transposable elements in the genome, where our DNA has accumulated all these virally originated pieces that have been suppressed. They've been just locked down. They're not allowed to express them protein, but misfolded tau gets into the nucleus and exposes certain areas of the genome to transcription, and then they get transcribed into protein, and the immune system has never seen these things before. And so you have an immune reaction. This could be very important. It's just starting researched. So keep that in mind. Protein homeostatic defects. The garbage disposal system of the cell. If you have misfolded proteins, they get tagged for disposal. If you have them aggregated where they're not supposed to aggregate, they get tagged for disposal. And these can clog up the garbage disposal. So then other types of protein can't get disposed of. And so this could be a reason why we have so much co-pathology in these diseases. Inflammatory dysregulation that often involves the microglia, which are the brain's blood cells. You all know that. The multiple misfolding proteins can interact with each other to produce even more damage than they would additively. Then we have genetic susceptibility and modifiers, including epigenetic changes. These could be environmentally imposed or imposed just by stress. And then it's inherited. The epigenetic changes get inherited. And there's a bunch of exposures and experiences, usually not with a whole lot of statistical support, but they're very, they're things that can really incite further research. Now, within the past 5 or 10 years, there's been this real breakthrough in the form of cryo-EM. That's where the sample, still in its aqueous medium, it doesn't get embedded in epoxy or paraffin or anything. It just gets flash frozen to an extremely cold temperature. And this allows a much stronger electron beam to be used in the EM. It's a strong enough beam that it would fry the chemical structure of samples that are not frozen in ice. And so this allows us to see almost to the atomic level what the structure of these proteins is. And the software will take multiple views and will reconstruct them into a two-dimensional projection, see here in that black and white picture. And these misfolding patterns group themselves into classes. There's an AD group, there's a corticobasal degeneration group, and there's a PSP-like group. If you stare at these long enough, you can see certain commonalities among the folds. And those blue dots, that's non-proteinaceous stuff, and we don't know what's in that because insoluble globs of things don't lend themselves to chemical analysis. And the same thing goes with alpha-synuclein. 3 classes of alpha-synuclein misfolding. Notice that the Parkinson's and the dementia all have the same misfolding pattern. That's very strong evidence that these are the and that the details about which clinical features they have and exactly which populations of neurons are affected, that's probably a result of strains of alpha-synuclein, but not the basic misfolding pattern. So how, I'm kind of going to ping pong back and forth between alpha-synuclein and tau, so I hope you can bear with me. Tau, the gene MAPT, microtubule associated protein tau, has 16 exons. You see the 0 and the 4A in there. And in normal adult human brain, about half of our tau, the other half is 4R. And what makes it 3R versus 4R is whether the 10th exon, whether the transcript of that exon is included in the finished product. Those R1, R2, R3, and R4 are called the repeats, the microtubule binding repeats. Those are areas that bind to the microtubules. They're not exact repeats of one another, but they're close. But in the tangles of Pick's disease, it's all 3R. In the tangles of PSP and CBD, it's all 4R. In the tangles of Alzheimer's, it's 4R and 3R in equal amounts, just like in normal. And then down at the N terminal, you see the 2 and 3. They are also alternatively split, and the physiology is only just starting to get unraveled. There is some significance. So these strains, think of the strains of these proteins as like broods of dogs. You know, they breed true. The puppies look like the parents, and they have different properties. However, there's multiple variables that can distinguish one strain from another, and I list those in the red square at the beginning. Difference in isoform composition, that's the 3R versus 4R. Post-translational modifications, these are very small molecules attached to specific points on the main protein molecule that are normal, that help regulate the behavior of that protein. And but there can be too many of them, or they can be in the wrong places. And I list the ones that are most important for the neurodegenerative diseases right there. The last one, O-glycnication, that's a sugar called acetylglucosamine, and you'll see more about that at the end of the lecture. They can be truncated. There can be these non-protein components that I mentioned. Then, so what does that do to, what do all these changes do to the properties of the fold of the protein? It affects the folds, it affects the twist geometry. Forget when the fibrils are first formed of these proteins, it's a stack of the protein. So if you have one stack, one protein here and another stack here, and they line up perfectly well together, they'll make a straight fiber. But if they line a little bit off kilter, then there's a progressive twisting so that the finished fiber will be twisted. You can see that in regular electron microscopy. Then there's aggregation kinetics and seed amplification assay results. That's important for diagnostic use of the SAAs. Different affinities for different PET ligands. That's a huge thing now. I mean, you can make a PET ligand that seems to work really great for tau protein in one disease, and it doesn't work for another disease. And it's probably the strains. Dependence on cofactors. There are cofactors that influence the behavior of proteins and may be different for different strains. Antibody vulnerability. That could be why the antibodies, the monoclonal antibodies that have been tried against PSP haven't worked so far. Resistance against protease. That's kind of a lab research thing. And then at the cellular level, the different strains have different degrees of loss of microtubule binding, especially with tau, different membrane interactions, different interactions with RNA binding proteins. So that's about transcription. Then there's importance of synaptic spread, the spread rate. Remember I told you about how the misfolded proteins template themselves. They get released to the original cell and into the next cell, either through a synapse or through direct proximity to just side-by-side location of the cell membranes. And different types of diseases and maybe different subtypes of diseases have different proportions of synaptic spread to the proximity spread. And the strain of the offending protein may affect that. Then there's selectivity for different neural systems. This is obviously a good way to explain the subtypes, the clinical subtypes of these diseases. The cell selectivity, whether it mainly affects neurons or glia, oligos, and recently there's even been an ependymal cell selectivity. And the insoluble aggregate form, in other words, whether the tau forms a neurofibrillary tangle or a tufts in a tufted astrocyte or a astrocyte plaque, there's neuropil threads, there's a whole litany of these. This shows the classic light microscopical large inclusions, the glial cytoplasmic inclusions of MSA, the Lewy bodies of DLB and Parkinson's, the tufted astrocytes of PSP, and the astrocytic plaques of CBD. And these are probably not toxic themselves. They are probably adaptive. They take the soluble misfolded proteins out of solution and concentrate them in these insoluble globs, which are probably, they're not accessible to anything, and they're protective. We don't know for sure. The at the bottom there just shows the syndromes that associate. There's a lot of overlap, and that's emphasized by this slide, where the pink rectangles are the clinical disorders, and the blue, green, and purple are the pathology pictures. And look at all that overlap. The only clinical disorders that are faithful, one, Richardson syndrome of PSP and the pure akinesia gate freezing of PSP, two subtypes. So more about subtypes. I'm going to go through these quickly. In PSP, we have 10 known subtypes, maybe an 11th, which I'll talk about on the next slide. The original was Richardson syndrome, described in 1963, and that is now known to comprise only 50% of all the autopsy-proven PSP. The next most common is the PSP Parkinsonism, described in 2005. The next most common is the frontal and behavioral form. Others are 5% or less. The cerebellar variant, which you see down at the bottom there, was originally described in Japan, and for years it was only found in Japan until Western neurologists started seeing more and more of it here, and I think it's just a matter of awareness. There you see the different survival rates of most of the subtypes in that Kaplan-Meier curve, and that PSP-PF, that stands for postural frontal. That's an 11th subtype that was identified by this group at Mayo Jacksonville using their brain bank. It comprises 32% of all PSP, and it has a more malignant progression than any of the others, including the Richardson syndrome, which is now second most. Keep in mind, this is just one paper at one place, and also brain banks tend to attract atypical cases because a family that's been told, clearly had PSP, all through their care, and they had confidence in the neurologist, they're not likely to request or consent to an autopsy. In MSA, there are two subtypes, the cerebellar and the Parkinsonian being 70%. And both of them, of course, have a lot of autonomic problems. And I'll talk more about other issues in PSP later, but right now we're just talking about the subtypes. Corticobasal degeneration is kind of this chimera. In fact, there was once a paper published from the group at Mayo entitled, "Does CBD Actually Exist?" About half of the patients with the corticobasal syndrome, this highly asymmetric collection of motor things and cortical sensory stuff, only about half of those patients turn out to have the pathology. And then there's a PSP clinical variant, a language, a cognitive, and a posterior atrophy with visuospatial. Dementia with Lewy bodies, same thing. There are 5 variants. About half have the classic cognitive appearance, and the others have components of the classic kind that are especially severe or early. But I don't want you to get the impression that basic cognitive style DLB does not have all those others besides the 4 that I've listed there. Okay, let's get to epidemiology. I could rattle off the prevalences of all these to you, but it wouldn't go in one wouldn't go in one ear and out, even make it into the first ear, because you would be asleep. So I'll just express it in terms of the prevalence relative to that of Parkinson's. So if Parkinson's is 100% and Alzheimer's is 400%, then DLB is about 15, and you see the others, PSP 5, MSA 3, and CBD 2. We used to think that CBD was only about 10% of PSP, but it's really about 40% of PSP, 5 versus 2. Now, look at this over on the right, PSP, the preclinical population may be 50 times larger. Why do we say that? Because the bracket there that says about 3%, there are these studies in places with a lot of retired people, Sun City, Arizona, for example, where people sign up to have their brain autopsy when they die. And so of people who die, neurological problems, about 3% of them have PSP change. Does that compare to the population prevalence of regular PSP, of overt clinically diagnosed PSP? It's 50 times as much. And that's what all the arithmetic here points out. So this would be great if we could identify those preclinical cases with some kind of really sensitive marker so that they can be enrolled in clinical trials of neuroprotective drugs. Exogenous risk factors. There is not a lot that we know. So this is all very kind of preliminary still, even though there have been a fair number of studies. The thing that's strongest for PSP is lesser educational attainment. This is also true of Alzheimer's. We don't know the reason for this. And the second most likely of these Ananaceae fruits. This is a family of fruits that has a mitochondrial toxin, which is a complex 1 inhibitor. And it's been implicated in a well-done case control survey in the region where there's this disease called Guadalupean tauopathy. And those patients who have the tauopathy are more likely to have consumed these 2 fruits, sweet sop and sour sop, compared to controls from their communities. And those fruits have adenosine, which is that complex 1 inhibitor. There's this fruit called the American pawpaw, which is closely related, not the same genus, to the sweet sop and sour sop. And that's been grown in the southern many decades. And it's consumed it's very popular fruit there, and it's making its way into the north. And don't know the implications epidemiologically. There's never been a prevalence or incidence survey of PS in the southern U.S. and comparing it to the northern U.S. Don't know. But I can tell you that if you take a nonicin and you inject it IV into a rodent, the rodent comes down with a Parkinsonian motor syndrome and a tauopathy in its brain. Okay, metals, 3 kind of weak threads here. One is a survey of U.S. military veterans who had PSP. And the controls were other veterans who did not have PSP. And the ones with PSP were more likely to have used weapons frequently in their military service. And discharging of weapons does liberate into the air all sorts of metals, not just lead, but lots of different things. And that's a pretty impressive odds ratio. It's 3.4, as I recall. To an epidemiologist, that would be astonishing. A 3.4 odds ratio. That's pretty good. But we don't know if it might be that maybe people who volunteer for the jobs in the military that involve shooting weapons might have different things going on in their brain that make them behave that way. So the jury's still out. Waterloo cluster implicates metals. Waterloo is a town in northern France where there is a cluster of PSP, autopsy typical PSP, with a observed to expected incidence ratio of over 13. And in that town, there is a very heavy problem with metals contamination from industrial activities over most of the 20th century. And I've worked on that. If we have time at the end, I'll show you a few slides on that. In Luxembourg, there's been a standard case control risk factor survey that does implicate metals. There have been other case control similar surveys elsewhere that have not implicated metals. Now let's get to the differential diagnosis. Don't start reading through all this. Oh, by the way, I'm going to make these slides accessible by one means or another. Deepak, maybe you can do that, or worst comes to worst, you can just email me and I'll be happy to send you the PowerPoint deck. So no need to scribble. I should have mentioned that at the beginning, my apologies. The CurePSP Centers of Care, it's a network of now 41 sites, US, Canada, Britain, Italy, and Germany, that published a couple of years ago a guide for general neurologists in how to differentially diagnose the atypical Parkinson's. And there's some principles I want you to come away with instead of reading all this text. Number one, you can almost always make the diagnosis from a good history of physical and an ordinary MRI. That's number one. Then there's an off-ramp. That's what the kind of brownish big rectangle at the bottom is. We call it conservative option. So if the history, physical, and MRI don't give you an answer, there are some patients that just don't want to be worked up any further. Maybe they're just too sick for whatever reason. They just don't want to deal with doctors. And you can say, okay, I can tell you have a progressive condition for which we do not yet have a cure or even a slowing the progression, but I will stick by you. I will be available to take care, to treat on a symptomatic level your symptoms as best I can. And if there are any new things that arise that might be diagnostically useful, just pick up the phone and call me. And maybe a new symptom will allow me to provide a more refined diagnosis. You have to stick by these patients. That's another basic message I want to get across to you. So one is the history, physical, and MRI is enough. Another is that there's an off-ramp in this process. And the other is do not just abdicate your contact with the patient. Do not just send them back to their primary care doc. You have to be available to them because the primary care doc is not going to know if some new symptom is as an expected part of their atypical Parkinsonism. You know, the primary care doc is going to say, oh, you better go to the emergency room and get worked up. I have no idea what this could be. It could be dangerous, but you should know better as neurologists. Okay, so if the patient does want to get more aggressive, rather than just going to then you start applying biomarkers. And I'll talk to you about biomarkers. And if that doesn't give the answer, then you can go to the off-ramp again, or you can start doing workups for selected diseases in that long list I showed you of the 60 odd diseases that can sometimes cause motor Parkinsonism. Okay. Other diagnostic things. You've probably all heard of the hummingbird sign in PSP. It's not everything it's cracked up to be. There's see if I have a. Can we see the first? Okay, good. Here's a normal midbrain. You see how it's a nice plump shape there, similar to the hummingbird with its beak. And you often see hanging off the front. It looks like a worm hanging off the front. It's actually the fornix. So here's what it normally in a. I mean, this is a normal brain, and in a middle stage PSP, you can see the midbrain is shrunken, but the pons is hardly shrunken at all. And in more advanced PSP, the midbrain is shrunken even more, and still the pons looks not normal, but not nearly as atrophic as the midbrain. And the reason this isn't everything it's cracked up to be is that in the very early stages, when you really need a test, when you really need the marker, it's normal. You don't have the hummingbird sign. And the other thing is that obstructive hydrocephalus, not NPH, but obstructive hydrocephalus, the third ventricle can enlarge enough that it squeezes the midbrain down and can mimic a hummingbird sign. And also sometimes corticobasal degeneration and some other things can affect the midbrain preferentially without affecting the pons. And that will also produce a small midbrain. There are other quaint signs on MRI that are both just features of atrophic midbrain. So the Mickey Mouse sign is where the dorsal part of the midbrain is just narrowed laterally. And there's this, the interpeduncular fossa is U-shaped rather than V-shaped. You see how it's nicely V-shaped in the normal here? If it's U-shaped, that's a really good sign of PSP. But again, it doesn't appear in the earliest stages. And then there's the morning glory sign. Morning glories have this nice lateral margin, and that can happen in PSP if you have atrophy, as opposed to here, this margin is quite straight or even a little convex. Okay. I think I'm going to skip this in the interest of time. This is a way of quantifying the atrophy, the magnetic resonant Parkinsonism index, and in the right has a really good sensitivity and specificity. It's just that it's really hard to make those measurements. Formal criteria for PSP, published in the most recent one was published in 2017. I'm certainly not going to go through this because the tables and charts were 5 full pages in the journal. It's really complicated. It talks about multiple levels of diagnostic certainty, defines core features, mandatory features, exclusionary features, and supportive features. And each of those things has its own set of criteria. And here's the sensitivity and specificity compared to autopsy. Does pretty well, especially with the specificity of the probables. I was one of the senior authors of this. We came up with this suggestion of PSP. So, for example, if an unheralded fall, slowed down gaze, mild frontal behavior, disinhibited behavior, these things are just on their own are called suggestive of PSP. Of course, they're not going to be very specific, but it turns out they have very high sensitivity, and about half of them will progress within only 2 years to possible or definite. It's unlikely they're going to die that soon. For definite, you need to have an autopsy. Here with CBD, this is quite simple, very, very user-friendly. Only problem is it doesn't work very well. Sensitivity is pretty low, even later in the disease. Specificity is not up to snuff either. You'd like to get it over 90%. Most of the satisfy multiple phenotypes of CBD using these criteria, because the phenotypes don't specify which phenotype you have, unlike the PSP criteria. And the candidates who satisfy these criteria will also satisfy criteria for other neurodegenerative diseases. And the criteria, the model doesn't at all address the pathologic heterogeneity of CBS, where only about half of patients with CBS actually have CBD in their brain. This shows that phenomenon. This shows in multiple centers that these authors accumulated, it was only 33% rather than 50%. Usually it's closer to 50. PSP is not far behind as a cause of corticobasal syndrome. AD is not that far behind that. And then a bunch of others, including Creutzfeldt-Jakob disease and vascular disease, 19%. So this is, so CBS is a very slippery thing. And in MSA, these are pretty easy to apply, and they work quite well. MSA is a much more distinctive disease, easier to diagnose clinically than the others. The specificities of the clinically established, they don't call it probable and possible, they call it established and probable. Specificity is great. And to improve the sensitivity, the probable does reasonably well. And some other diagnostic clues to MSA, I've listed them all there. I don't need to read them out to you, except to point out that are the really specific things, the things that have a really high positive predictive value for a diagnosis of MSA are a jerky tremor, so that instead of being able to maintain hands like this or or a flapping type of tremor that you would get, a reentry tremor like you would get with Parkinson. Instead, it's a kind of intermittent, low amplitude, really fast myoclonic type of tremor. Cold or cyanotic distal parts. Anticolous, disproportionate to Parkinsonism. You see that in the gentleman on the right. The other diseases usually, they don't do that much. It's not the majority of MSA either, but at least it's fairly specific to MSA. Inspiratory stridor. You've all heard stridor. The patient will, not just when they're breathing normally, but just sitting there, they'll suddenly go, that's inspiratory stridor. And the polymini myoclonus, much in the other diseases. MSA signs of, MRI signs of MSA, you have the hot cross bun sign. The pons looks like it has icing in a cross pattern. It's a British Easter or Christmas custom to have hot cross buns. There's rarefaction of the middle cerebellar peduncles. You see a little hot cross bun sign in this patient too. There's a normal appearance, and then you see there's atrophy of the pons. That's way disproportionate to atrophy of the midbrain. It's a pretty nice looking midbrain, but clearly atrophic pons. And there's also in the axial cuts, you see these the iron deposition in the lateral putamen. You see this putaminal slit, this white slit here. It's not a layer. That are good signs of MSA, but again, not in the really early stages when you really need them. Then there's cardiac MIBG. It's not, is it available at this medical center for neurological patients? I see nobody saying yes, so I guess the answer is no. It's more popular in Europe. It's a measure of whether the patient's sympathetic autonomic problem is central or peripheral in origin, the first order neurons or the second order neurons. So if this ligand is taken up in the heart, then it's the central neurons that are affected, or the patient's normal. But if you have deficient uptake, then it's in Parkinson's or DLB, because that's the second order neurons. Sympathetic neurons that are affected. In DLB, we've also got formal diagnostic criteria. The thing is, since DLB and PD are really two ends of the same spectrum, not even the ends, they're kind of the two halves of the same spectrum. I don't see much point in distinguishing DLB from PD. You do have a few things that are present at that end of the spectrum in DLB that, as far as I know, don't happen much in PD. The prominent slow wave activity in the EEG and the reduced posterior brain, the occipital posterior parietal reduced uptake on SPECT. So here's the dopamine transporter imaging, the DAT scan. This cannot distinguish in neurodegenerative Parkinsonisms. It looks the same in PD and PSP and all of these. And so really the utility distinguishing between, say, something like a PD essential tremor, where sometimes the tremors can look very much alike, and sometimes patients with PD are bradykinetic. Or distinguishing between a degenerative Parkinsonian disorder and one of those, and some metabolic issue. Then FDG PET, this is a measure of metabolism and also of perfusion. Can't see what the minute hand is. About 5 minutes, okay, we're good. And the crucial finding here that I'll point out to you is this cingulate island sign in DLB. The cingulate gyrus, it goes, it arches its way from between the front and the back of the brain, and there's one on each side, of course, and it ends this cut of and catches it in the occipital lobe where it's normal. But the rest of the occipital lobe is reduced in its uptake. And so you have this island of normal in the middle of this abnormal, and that's called the cingulate island sign of DLB. And the others you can read there have their own particular patterns. Usually this is not all that helpful in making a diagnosis beyond all the other means at our disposal. And just to show you the impressive MRI in the corticobasal syndrome, whether it's from corticobasal degeneration or Alzheimer's or PSP, it's still a very asymmetric cortical and subcortical atrophy. And the biomarkers are, there's not that much available yet. The SYN1 in skin can distinguish synucleinopathies from non-synucleinopathies. And the SAA in the spinal fluid can do the same. Other than that, there's really nothing that's ready for prime time. Neurofilament light is often mentioned as a biomarker, but really it's only useful for tracking progression. It's not useful for differential diagnosis. This whole situation is changing rapidly, however. Here is, this is from a paper that we're about to submit. This table, the paper is about differential diagnosis of the atypicals. This table just does one-on-one pair-ups of which diagnostic tests you would use if you are trying to distinguish between two specific diseases. Now, treatment, you have, first of all, PSP. There are some trials that are either in progress or are going to be starting within the next few months. This first one is an O-glycanase inhibitor. That sugar, that's a post-translational modification, that occupies the same sites on the tau molecule as the phosphorylation, and the phosphorylation is a major cause of misfolding. So to prevent the phosphates from attaching, the brain normally will attach this N-acetylglucosamine to those sites. And when it needs to attach a tau, it will act, an enzyme called O-glycanase will remove the N-acetylglucosamine, the sugar, to allow the phosphate access to that site. So if we can inhibit the O-glycanase, then we can prevent the phosphate from occupying that site, and that's what this drug does. Selenium, you can buy it at the drugstore. It reduces phospho-tau. That trial has been having problems, I think, because they have too few sites for the number of patients they want. That's just in Australia in any case. And the next three are all drugs that are going to be in the PSP trial platform, where there's, I think, about 40 sites around the US that are all recruiting for using the same administrative structure. These three drugs are going to be tested at the same time, and a placebo group is going to be recruited at the same time. So 25% chance of being placebo randomized. So the first one, AZP 2006, is a progranulin enhancer. So it improves lysosome function, also reduces inflammation. The LM11A31 binds to a nerve growth factor receptor and modulates it somehow. And the drug company is very stingy with details. And the ADVAC is a active anti-tau vaccine, which addresses the C-terminal. Some other are about to reach clinic, probably in the next year or so. This antisense oligonucleotide, which reduces tau expression, has to be given intrathecally. This GM1001 it's an anti-inflammatory because it reduces, it's a tau telomerase reverse transcriptase, reduces the exposure of these transposable elements to the transcriptive machinery. Bepranemab is a monoclonal antibody against the mid of tau. The others I'm not going to discuss because they are further from and I have some doubts about whether they're really going to work even when they get there. But you could read that at your leisure. This was a combination of two drugs that addresses two different mechanisms. It did not work in phase 3, but I like their spirit of addressing two different mechanisms together. I think that's what we're going to have to do. Just like AIDS and hypertension and diabetes, all sorts of things require more than one drug. In MSA, we have a growth, an oligodendrocyte growth factor stimulator. We have this monoclonal antibody to alpha-synuclein, inhibitor of something in the inflammatory, and also it blocks NMDA, so there's reduced excitotoxicity. Here is an antidote on the microglia, and here is binds to alpha-synuclein. It's not an antibody, it just binds to a niche in the misfolded alpha-synuclein. It's designed, once we knew the cryo-EM structure of misfolded alpha-synuclein, such a drug could be designed. This is an amazing result of modern technology. It'll be even more amazing if it works. And finally, there's DBS, there's transcranial, this is for MSA again, transcranial direct current, autologous mesenchymal stem cells, allogeneic stem cells, in other words, multiple donors, not the patient. And this Alito is a nerve repair protein. This company is extremely cagey about scientific details. And 9 minutes over. So thank you for your attention. Happy to take questions.
Well, thank you so much. That will be a full spectrum from very basic science descriptions to clinical and then translational at the end. So I have some questions here online, but before that, I will obviously give you guys privilege over that because you are here on site. Any questions anybody would like to ask Dr. Golbe? Okay. I have one question before I move to online. It's not about your presentation, but Dr. Golbe just shared a very nice story with me that how he got into neurology, the summary of which is who is on your service as a medical student with you in terms of attending and dictates if you will go into neurology because that's what happened to him. But I'm curious what really made you focus in such a niche of atypical, but even more so within that PSP? What's the backstory of that?
Basically, I was working on Parkinson's under my chairman. His name was Roger Duvlazan. He was a world's authority. And he was getting sick and tired of his series of patients with Parkinson's being contaminated by patients with PSP. It was just a statistical noise for him. He wasn't that interested in PSP on its own. So he assigned me the task of figuring out what to do about this. One thing was to create the first diagnostic criteria for PSP, which I did. It was published in 88 or 89, and that was in use for a few years. It wasn't autopsy-based, so it gave way very quickly to the 1996 criteria. And the other thing that he had me do was measure the prevalence of the disease so we could have some idea of how many to look out for. And so I did that. And as long as I was collecting all these patients, I did a case control risk factor survey, and I did a video eye movement study. And so I really got interested in PSP. So after all these things were finished, he said to me, okay, that's you're done with PSP. Now join me back in studying Parkinson's. And I said, yeah, I'll do that, but I'll also stick with PSP. Thank you very much. And so that's how I became a PSPologist.
I like that, PSPologist. We have some online question from just one person, but they're very interesting speaker. This is Dr. Alberto Espe, whom you likely know from Cincinnati. So there are 4, so maybe we can briefly address, and maybe I'll connect you with him on email for detail.
You don't need to connect me with him. I know him very well.
Okay, yeah. I mean, I will paste these
I
questions.
understand.
Yeah. The first question from him is the word strain borrowed from virology appropriate to use for proteins. A viral replicates with fidelity, but can proteins replicate to generate identical copies? or generate polymorphs. So he's saying, is it appropriate to use the word strain for the proteins?
As far as I know, when a misfolded protein like tau or alpha-synuclein propagates itself, the resulting misfolded proteins are the same misfolding, including post-translational modifications. And this has been shown by injection of fibers taken from autopsied human brain with, say, autopsy-proven PSP or Parkinson's, and injected into rodents and in a specific site. And then when you sacrifice the animal, there is spread. It's an animal that already has a transfected tau gene. So the mouse's tau gene and gets misfolded and transmitted through the brain.
Yeah,
in the same folding pattern.
Got it. The next is, are brains of people who died with PSP pathology but without PSP symptoms, so-called preclinical PSP, is it possible that the PSP pathology is a demonstration of a reactive protein, reactive pathology being equal to marker? More generally, is PSP pathology the cause of PSP or its consequence?
Don't quite understand.
Well, you can move on then in favor of time. Also, he seems to have deleted this question, but let's take one more, which I think is a very broad question and very helpful treatment-wise. Anti-tau pathology treatments dominate the disease-modifying pipeline in PSP. Number one, is there falsify the pathology causes disease hypothesis in any of the trials? Number two, are any pro-monomeric tau being considered? Can you repeat the question?
Well, the first question is basically tau pathology causes the overall disease as opposed to maybe being a consequence of overall disease. No, we do not. Except, I mean, we know that you can inject tau into a mouse and the mouse gets sick with a tauopathy, but that doesn't mean that that's what's going on in human disease.
Yeah, so I think what he's wondering is, does it, like any of the trials falsify not succeeding? Same story with alpha-synuclein and world for that matter.
I suspect that this question comes from
yes.
From the trials that pretend that would falsify.
Yeah. Any pro-monomeric tau being considered?
Monomeric
tau.
Oh, ways of preventing tau from aggregating.
I suppose, yeah.
None of the current trials, but I've certainly seen literature in animal models that is testing tau anti-aggregants.
Yeah. Okay. And this is from Dr. Shabir Merchant at, I think, the IDMC in Boston. Considering mixed pathologies noted in several of these neurodegenerative disorders, should we consider using biomarker-based targeting for neuroprotection, targeting multiple mechanisms instead of arbitrary synuclein tau amyloid labels?
Well, I wouldn't call it arbitrary because it's the main protein aggregating. But yes, the answer to your question is absolutely. I mean, it would be great to be able to target proteins because there are multiple proteins getting aggregated, even though they are at low levels. And so we call them co-pathology, but it's still pathology.
Yeah. And there is one question here, Dr. Thomas, Elisa Thomas, our residency program director and neuro-oncologist.
Thank you so much. The really striking to me, and I'm curious if there's a sense about whether those patients would live in a pre-PSP state forever, or if they're like, and it would take something else to make them have PSP, or if like the cat's out of the bag and they're going to get it if they just live longer.
No, the experts are certainly open to the possibility that this is a different condition, that maybe this very slowly progressive pathology, and that if it ever bloom into clinically overt PSP, the patient would have to live 200 years or something. Yeah, that is a possibility.
And ask one, this may be a biased question because you know from our work on unified diagnostic criteria. So all these various diagnostic criteria obviously are nuanced and complex, but overlapping by the nature of the elements involved. So do you feel a unified diagnostic criteria schema would be helpful rather than having these complex, separate, overlapping criteria exist in not relative silos, but complete silos, but relative silos? So would a unified criteria help in your experience and views?
If we could come up with some validated criteria for multiple diseases, then that use the same set of variables, then yes. But if you just try to take the evidence that's in the literature now, I don't know that the result would be any better than just doing them separately and then just using your clinical acumen to do tests that by markers to examine to resolve remaining uncertainty. To an extent, the differential diagnosis of these atypicals is very much a Bayesian exercise where you form a hypothesis based on your exam history and MRI, and then you might do testing for very carefully chosen testing to shed further light on it to improve the hypothesis. And that would be very hard to automate, I think, with current data.
One more, last one. This is especially because it's very helpful clinically and is coming all the way from 7,000 miles away from Dr. Vinay Goyal, who is a movement disorder neurologist at Medanta. Does speak in different types of PSP, and can it help in prognosis that way?
No, not as far as I know. I mean, PSP can give you a variety of different speech problems, hypokinetic, ataxic, spastic. And I don't know any real clinical pathological work that's been done on that. I'm not saying it doesn't exist. I just can't think of any at the moment.
Yeah, it's interesting. I'm thinking tachyphemia, like particularly, I think like some patients do have distinct phenotype even within PSP. So I think it's a very nuanced clinical observation, something to explore maybe. Well, I think with that, thank you very much for coming, everybody, both in person and Zoom. Have a good day. Thank you, Dr. Golbe, for coming and giving us such a wonderful talk. All right.